I asked them to start the stream because people are getting online. They were also, I was, somebody from South Africa was calling us.
So I cannot go away.
Yeah. Is that obvious or am I?
No, that's what I asked. It makes sense.
Yeah.
If it's live streamed, then
Yeah, absolutely.
Okay. So then I don't know when it's going to be okay for the live stream.
They're going to start as soon as you start. So, yeah, they're starting up.
Well.
You're welcome to use that if you want.
I think it would be okay. So, shall we start? Perfect. So, I would like to welcome you all to this day, this very special day, the Evaluation Day, and specifically in Geneva. So you don't get me. They said I have to stand here, so I cannot go around, but hopefully you can listen to me. Is it okay? Perfect. So I would like to welcome you all here, specifically to this Evaluation Day and in Geneva. So it's since 2010 that Evaluations Day are happening once a year. This is going to be the 8th time that we have this fantastic day here. I think that little by little this day has become quite a popular one, quite a well-known one. More than 100 registered people on this event today, and the live streaming that will add much more people and will be able to reach them much more than the face-to-face. As I said before, this Evaluation Day has become a very important day. We're very happy to host it here in Geneva. As you know, each year is going around from OC to OC. This year, here in Geneva, we're happy to have you here. There's a grey day outside, but a shiny day inside, so I hope that we will profit from all the 3 presentations that we have today. So going a little bit into evaluations as such, as you know, we have an evaluation center in Stockholm, an evaluation center in Vienna, and a focal point in Paris. These 3 groups are working quite along with each other. There is a very, very good communication, so much so that there is this platform, the International Evaluation Group, that works very much jointly for lessons learned, for methodology, for cross-fertilization, with this idea that has increased day to day to systematically try to learn from our projects and this idea of this mutual accountability that we have to each other. The idea for them is, and specifically the purpose of this day, is to bring the medic and operations from MSF and this fantastic community of evaluators together with the aim of trying to improve our projects and evaluations being a tool for that improvement into our projects. There's a very good website that the International Evaluation Group has. I advise you all to go into it. It's a very intuitive, easygoing website where you will find all the material that we're going to discuss today, plus much more of all the evaluations intersectionally that have been done and sectionally as well, plus learning material. So I invite you all really to go through it. It's, as I say, very easy to use. Coming a little bit much more to the day-to-day, as you know, and as you saw a little bit the agenda, there are three main topics here. There is the first session is going to be concentrated in HIV, HIV still being quite high in the agenda of MSF. So we will profit from this first session on HIV. There's going to be a second session on advocacy, quite top in the agenda of MSF as well, much more to try to improve our advocacy approaches today. And the third one, that was very high in the agenda a few years ago, and I think that now we're a little bit distant so as to still put that passion that we have for the topic, but also try to detach ourselves and really take these lessons learned when it comes to Ebola. The idea today is really, previously the evaluation day had a focus on methodology and some of the evaluations were discussed to their detail. I think that there was a shift since a couple of years so as to, yes, methodology is extremely important, but it's not necessarily for the target population or for the target group that we have here, where we have operation and medical people that are much more interested also to understand how to take those lessons learned to a concrete action. So today we're going to concentrate much more on those lessons learned or outcomes of these evaluations and how the medical and operational people manage to either implement it, which were the challenge for their implementers, where they are accurate, where they're not accurate, and the discussion going much more on that side, that really the method of evaluation that has been taken. So what the medical and ops expect, I think that, again, try to express whenever an evaluation comes to them, those challenges that they are confronted whenever an outcome and a recommendation comes in. I think that the evaluations would like to listen part of those challenges and how to improve so as to, again, the final objective, have better projects today and tomorrow. I will leave it here. I will give the floor to Boris that will take us through the agenda and then start immediately with our first session. Thank you again all for being here.
Yes, it's working. Hello everyone, thank you for coming. I just want to run through some practical points, if I can find my notes. So we have 3 sessions today, and in between those sessions we will be providing lunch at 12 o'clock, and there will be a coffee break at 4:30, and I hope that's enough to sustain you for the day. Let me look here. So I've chosen this microphone. So these microphones will be carried around by 2 volunteers in the audience. If you have a question, please raise your hand and take the microphone. We need to speak into these microphones so that the people streaming can hear the questions. So you'll have to bear with us while we get the microphones around the room. And please hold the microphone near your mouth like this and not like this, so that everyone can hear you. What else? There will be questions coming online through somebody, so we also have to make room for online questions through Kristen in the corner there. And otherwise, I think it will be reasonably self-explanatory. Apologies for the venue. We wanted to find an auditorium with streaming facilities and audio-visual facilities, and the rest of it kind of came with the venue, which we couldn't do much about. We asked them to take their logo off the door, but they weren't willing. We'll try better next time. Right, I think we will leave it there for now. Are there any questions before we get going? No, so let me introduce Anneli Eriksson, the moderator for the first panel, and invite the first panel to come up to the... No? No, just Anneli. Do you want to stand here?
Yeah, I'll stand, or I can...
Actually, if you run with that mic, because I need to turn this on.
Okay, so I'll be fine with that. I'm not going to be alone for the 2 hours, I promise. It was just now. No, so I wanted to introduce this first session, which is actually 2 sessions in one, because we have approximately 2 hours, and the first hour will we focus on 4 different evaluations of different types of HIV/AIDS projects. And in the next hour after, we will have a panel of 6 distinguished MSFers and also externals who will discuss around what did we learn from this, and where you, of course, also will be welcome to join and to intervene. And so we already discussed about the HIV/AIDS evaluations, but we have, I mean, in the recent years, there's been quite a number of evaluations done related to HIV. Some of them because it's part of the funding and what we're expected to do and report back to funders. Others because this it's really, in many ways, we've been working on HIV since 15 years or more, but we've been treating since 15 years, but there's still every day, every time, there's new questions and new strategies to be tested and tried, and so therefore also evaluations are focusing on this. And so the idea today was to take stock of a few of these evaluations and looking at them in the light of the MSF strategic framework to see is there something we can actually learn from these evaluations? Do they raise questions? Do they give us guidance on where to move forward? Because as you see, no, you don't see it, but the title of the whole session is MSF and HIV. Is it an end of an era and start of another? And in that case, where are we heading? Some of you know this strategic framework very well, and others not. And I'm not going to read the whole thing through for you, but I'll give you a few highlights so that we're sort of starting at a similar level. And so in the strategic framework, there are different focuses and also a focus on what type of population or populations groups that MSF should be sort of heading its assistance towards. And one important area is countries with could be low prevalence, but also low coverage or low access to treatment, i.e. countries in Western Africa, Central Africa. Another area or another context in this is complex emergencies or conflicts and other emergencies, people on the move, displaced, and their access to treatment. And of course, a third one is countries with a high prevalence where treatment has been rolled out, but where there are still pockets of populations that have problems in accessing or in other ways have higher risks of getting infected, and where we also see the need to continue our work in order to ensure retention and treatment with second-line treatment, etc. In the focus on population, there is still a focus, of course, on in low access populations that are living with HIV are the focus, but we also have a specific focus on children, adolescents, young women as particularly vulnerable for the infection, but also in having problems to access treatment. There's also focus on people most at risk, intravenous drug users and others who are sort of already outside of the system and at the same time really very much at risk for the disease. And when it comes to strategies, these are many: community empowerment and engagement, integration of TB with HIV, and also integration of hepatitis C in the program. But one of the major strategies is, of course, integration in general of HIV/AIDS. And there, when we talk about it today, I think we will talk about different meanings of integration. And just to give you a few of that, because of course integration can mean integration of HIV projects into the existing healthcare system, but we can also see it from another perspective in terms of integration of an HIV/AIDS component into MSF's ongoing projects, which is, for instance, the case when we're looking at it in conflict settings. And all of these will be presented and covered in different angles when it comes to the presentations. Yes, so the first hour we will have, as I said, 4 presentations, and we'll try to make sure to have some minutes in between for some questions and answers with the evaluators who are presenting. And then in the panel discussion, we will not have the evaluators, but they will of course also still be available to answer questions if more arises towards them in the rest of the morning. And the first evaluation that we will present is one looking at the decentralization and reinforcement in peripheral areas in Guinea. And it's an OCB project, and it's Miranda Brower who has done the evaluations. And Miranda is an experienced evaluator who has done several evaluations in the same field on HIV and TB. Most welcome.
Thank you very much. Can everybody hear me? Good. We have been given very strict orders to keep time, so shout if I really go too fast, but I think it will be fine. And the question that I will be looking at is, in low HIV prevalent countries, should we border at all? And Annelie has nicely outlined the strategic framework paper, so I'm not going to go through that again. It's the one on the top, and hopefully I will tell something on the road that we may want to get there, in especially the low prevalence and low ART coverage situations. So the evaluation I did about a year ago was done in Conakry, the capital of Guinea, and Conakry is a peninsula pointing out into the ocean and with a horrible traffic situation, like many other African capitals. And many years ago, MSF started the treatment for HIV in a MSF-only project in one of the health facilities in Conakry. And in collaboration with the government over the last couple of years, MSF has extended this to support decentralization into more peripheral health centers in the capital. And at the time of the evaluations, there were 6 centers supported by MSF. And to give a little bit of background on Guinea, it has about 11 million population and very high poverty rates. It's a low prevalence HIV countries with UNAIDS estimates at 1.7 in 2012, although in Conakry itself it's a little bit higher. And in the capital there's about 50,000 HIV infected people, of which about 50% do get ART, but that represents 76% of the people on ART in the country, meaning that outside Conakry it's a lot worse than in the capital. So what were the challenges that I encountered? It's a relatively weak health system, and that relates to infrastructure, to services available, to equipment available. And I think that the Ebola presentations this afternoon may highlight also weak systems. In addition, that healthcare is not necessarily free. There's not necessarily a fixed payment to be made by patients, but healthcare staff are paid by patients, and some of the healthcare staff are not on the payroll, so they are entirely dependent on the patient payment. And international law, as I may phrase it, has said that HIV treatment, care and treatment should be free, so that people who are not paid and are not supposed to get any money out of HIV-infected people are not really interested in treating these people. I would say that staff motivation is an issue in itself anyway. Low wages, poor working conditions, poor career possibilities, poor support for them as staff, as working. So that definitely adds to all these challenges. And then stigma is a huge issue. Many of the people in Guinea are Muslims and think that HIV is a result of your own fault, you're just being a bad person. You have sex with men as another man, or you are a sex worker, and good people, good Muslims don't do that. So what could we do? First of all, I like to say that it may help to keep things simple. What do I mean? And is to have clear algorithms and clear guidelines and try to allow the time to implement these. The field of HIV has the tendency to run much faster than most health system and staff can run, so that by the time one guideline or algorithm has been almost properly implemented, the next one is already out. Also, I think that HIV is just another disease. We should stop treating it as a special case. For example, in Guinea, and these are data from the WHO, maternal deaths per 100,000 population are much, much higher than HIV and TB. In addition, I think it will be good to provide the care at the lowest possible level with a good referral system, which I would again argue to keep it simple, probably symptom-based, and the example here, if comatose, is obviously not the one you would like to have because you want to refer before people get comatose, but to give a simple example. And to build capacity. That's a bit of an open door maybe, but I'll come back to that. So what could be the way forward? And the first thing is, and I put it as patients to the power of patients, because I do think that we need lots of it. It takes time. It takes time to change. I think we only have to look at ourselves, so that if you want to change something within your own life, it's not, usually doesn't happen overnight. I also think it would be good to have tender love and care for patients, obviously, but also for staff and the system. If it is staff that work under very different or difficult situations, then and have low motivation, we need to take time and approach them, well, as I say, with tender love and care, and the same would apply to the system. Give it time to change and build it alongside people. I also think it's important to invest in people. That is for local staff, I mean, that's then the capacity building, but also for MSF staff. I thought there was a tendency to fly in expat experts, and then that does not necessarily result in building that sort of capacity within the country. And for the MSF staff, I think that if you're in a system where mentoring and coaching is much more important than providing clinical care, then you need to look for skills that are present beyond clinical care experience. A clinician who has experience in an HIV treatment program is not necessarily the one who can coach people also gaining that experience. I also think that we need to have advocacy at all levels, and that is from community up to the government and all levels in between. And we need that for a long time. Again, in the low prevalence situation where there may be other diseases or other problems present in the country that are much more sort of on everybody's today, everybody and every day's agenda, then we need to advocate for diseases such as HIV to be in the system. So, and then hopefully all that will answer the question as should we border at all, as yes, we should. Not only for human rights and low prevalence countries becoming a high prevalence country, but a boy like that's the wrong button. Like this one has much better chances in life if his mother is treated adequately for her HIV. And that was me. That's the first sign, so I am within time. I thank you very much.
Is this one on? Or maybe this?
Do you understand?
Oh, no, please stay, Miranda. I was just thinking, are there any particular question on the evaluation or the lessons learned that Miranda has presented? Or everything is clear and you all agree, yes? Okay, then we move on to the next presentation. Thank you so much, Miranda. So the next presentation will be on a very large, actually, evaluation where Geraldine Brun has been evaluating the rollout of the integration of HIV/TB projects in 6 countries for OCPA. And I know you've had some struggle to minimize this into a short presentation of today, because of course there are a zillion different findings and a lot of different areas that you could look into. Can you get it? We'll see, some technical. The text is too small? Yeah. Because you have it there also, but maybe that's a bit, no, it's okay. Okay, so I know that you've set out to focus on the lessons learned and the challenges, so please go ahead.
I will have to go quite quickly. So I will present this evaluation, which was quite a huge evaluation during 5 months. And so I will present only successes, lessons learned, and challenges, some of them, and what I found, some main one, focusing country settings and Muslim settings. Okay, this evaluation was of 6 projects in 4 countries on the integration, of HIV/TB services in regular MSF project, except in Yemen, which was a vertical one. Where population, due to conflict, lacked of access to HIV/TB prevention, testing, care, and treatment, and lack of appropriate follow-up when under ART. All 6 projects have shown real improvement in access and quality of HIV/TB care, and also improvement on children HIV positive. The cohort for the whole 4 countries from 2008, the first project, up to 2015, had more than 7,000 patients enrolled on HIV. More than 5,000 patients started on ART, and more than 3,000 patients active on ART. The cohort was at 70% female, except in Yemen, due to the conservative Muslim country. So I would present the main strategies important for me for integration of HIV/TB services, which were the MOH collaboration that MSF had, the medical coordination, the HR adjustment, and the location of HIV/TB services. According to the close collaboration with the MOH since the beginning of the project, even if he had a cost time, it allowed a greater MOH involvement and the anchoring of the project. Thanks to the strong collaboration, MSF OGBA could win the recognition and confidence of the authorities, and it helped to embed the project. MSF could push the collaboration between medical departments and ART side through HIV/TB trainings and awareness sessions to healthcare workers. And this was in all the four countries I'm talking about. And last point, MSF supported the PLWHA NGOs, playing a major supportive role, and this was really important, for instance, in CAR and Yemen. And it was one of the keys to implement a peer-to-peer strategy. According to HR strategy and setup, Flying HIV Expat did set up and support integration of HIV/TB services in the 3 countries, except Yemen, where MSF's choice was to train national doctors. And Flying HIV Expat is a necessary expertise to enhance quality of care, recognized by the medical team, but to share maybe between 2 or 3 countries. In Yemen, the difference, the project was not expatriate dependent, and this could continue to run, the project could run even with a high level of insecurity and ensure the continuity of treatment. According to insecurity, sure, it induced staff reduction. It has armed effectiveness and should not be seen as positive cost saving. About task shifting, it was operated with nurses, secretaries, matron, and midwives in line with national policies. MSF improved local staffing in quality and quantity in the hospitals. It ensured a continuum after handover, and we could have evaluated this in South Sudan, where the program was handed over when we evaluated. To make task shifting, and everybody said this, to make it successful in the long run, it would need really to have a technical supervision with the medical team, MSF medical team. About the location of the service, they are not always physically integrated, and it has an impact on loss to follow-up. Patients wish to hinder stigma and avoid disclosure, and it is better served in the midst of other services to avoid detection. And it was really, really seen in Niger. As an assumption, we could say that with an integrated location, more involvement and coordination between healthcare workers can be seen. A general recommendation, all implementation of HIV/TB integrated project should ensure an integrated building with the help of PLWHA, who has to help for the place to set it up in the hospital. The third part of my presentation is the integration of HIV/TB services. What's to highlight? First point about testing and counseling in the facilities. Okay, the increase in all the facilities, but also in the light of conservative setting and access to women. For this, for instance, in Yemen, MSF set up a counseling gender-based strategy with female counselors and male counselors, so to respect women's privacy. Also, in all the countries and projects, we can say that due to the large female cohort, it would be relevant to have much more female CHWs for sensitization work in community. Related to retention in care, it is higher in more stable settings and among females. Expert patient strategies in Yemen, supportive to HIV patients, improved quality of care and adherence. Where community support was achieved, retention in care was improved, as in Yemen and in Yambio. Availability of drugs, usually there were very few shortage, even if conflicts and log constraints. Success of contingency plans for maintaining and adapting access to treatment with positive effects on reduction of loss to follow-up. Though, when potential risks are not on the radar screen, CPs are of low priority, and that's what we've seen in Yambio and Niger. According to the mortality among the cohorts, it appears that projects having the weakest HIV/TB services team in terms of experienced qualified staff and number of staff and lower coordination had a higher mortality ratio, and that was specifically in CAR. So according to this, we can say as recommendation that upstream avoid the risk of defaulter when patient is referred for complication to the medical consultation. Downstream, MSF should be more present in IPD for those HIV suspected cases to offer HIV testing and ART treatment. And above all, strengthen HR at the HIV/TB services and set up a therapeutic committee for the follow-up of the cohort. Integration of PMTCT in ANC, PNC, and maternity was successfully realized in CAR, South Sudan, and starting in Yemen, and of course as option B+. Thanks to awareness and HE session, it raised acceptance of HIV testing among most of the pregnant women, and that was really impressive in Yemen. Though due to the country and the context. Nearly 400 pregnant women enrolled in option B+ at the end of the evaluation, not at the end of the evaluation, but in April 2015, when we could evaluate at the last point. 50% in Yambio project and 50% in CAR. As a recommendation, general recommendation, all PMTCT projects should implement support mother groups to keep loss to follow up very low. That was really an example in Yambio project. About the loss to follow up in the cohort, it has really an impact. And loss to follow up on ART represent about 26% of the patient in the 6 project. And the low percentages are observed where project had a strong peer support. And that was in Yemen, 15%, and 10% in PMTCT program in Yambio. So we suggest as recommendations that better track the patients with a one-stop system, and also closeness to patient with outreach provision dispensing, appointment spacing only with support, and ensure psychological support, respect to confidentiality, transport cost afforded, and provision of food for the patients. These are recommendations. Some of them are really already take place in the different projects. I make also a point on response to stigma, as for instance in Yemen, it was one of the main components of the program. Stigma was found the highest in conservative and Muslim contexts, that's in Yemen and Ndele in CAR. It played out on acceptance to testing and adherence to treatment. As a lesson learned, we can say that involving PLWHA NGOs for counseling and social support helps improving adherence. MSF launched advocacy, IEC, and capacity building strategy, and it helped to reduce stigma and discrimination with real success. For really short conclusion and some remaining challenges, I would say that how to set up the supervision and strategic guiding for HIV/TB cohort in large missions without flying HIV permanent position. Is it with a national one? I don't know. Expanding activities in already huge mission. It leads to competition activities. Third point, balancing long-term oriented activities and purely emergency intervention in one mission. That's a question. The long-term project, an ethical question on taking PLWHA on art, strengthened long-term planning with early exit strategy, handover, and sustainability. One of the last points, develop a long-term handover strategy to MOH. What can be done today to hand over in a few years? And last point, how to keep up acceptable level of quality beyond MSF in the hospital. And as a conclusion, integration has proven many advantages in context of insecurity or areas with little or no access to HIV care for population. It may be the only feasible option for HIV care. Okay, can be added to other humanitarian. The other thing I want to say, it's due to the new UNAIDS strategy for 2020, this target will not be feasible if integrated and innovative models are not implemented in places where HIV is not the main priority because of its prevalence, low prevalence, but a huge need because of the extremely low ART coverage. Thank you.
I think there's also space for a few questions, Miranda, if there are any. Let's see. Sorry, Geraldine. Any questions for Geraldine on this presentation? Yes, there's 2 questions. Maybe you can come up and...
Hi. I noticed in one of your first slides that there is a loss of 50% of the pediatric cohort. Did you have any explanation for that?
Can you repeat? I didn't hear.
Oh, sorry.
50, the first one?
So in your figures of the amount of people living with HIV, the amount tested, and then the pediatric cohort, you lost...
The pediatric cohort, yeah.
Yeah, there is a loss of 50%. Good, then I think it's the next slide. No, the previous slide then. No, okay. Yeah, so you have 349 children on ART, and you have 209 still active on ART. So that's a loss of 50%. Nothing to comment about this? C'est pas juste,
Excuse me, I just don't understand the question.
So you talk about loss to follow-up, and I'm just amazed by the amount of children lost to follow-up between the figures on the second row and on the third row.
I'm not talking about the loss to follow-up here.
So why is there such a difference between started on ART and active on ART then? What is this difference? Maybe I misunderstood.
Ah, okay, sorry, I am. Okay, the difference is well, you had you had loss to follow up, you had dead people, you had people that moved to other program, movement of population, displacement. That's the...
But the percentage of loss to follow-up, or I mean, the remaining children, the percentage is fewer for children compared to the adults, right? So that was the question.
It's more or less the same for adults. Huh? It's just that do we think 50% is acceptable? I mean, to lose them, whether it's by death or by loss to follow-up or by whatever other mean. Of course, it's 7 years. It's a long period, I understand. But is there something we should do to avoid this? Because it's not a little bit, 50%.
Mm-hmm. I know. To avoid this, that's why I wanted to highlight some recommendations and some action also that took place already in the different projects. And that's one point. And the other point I wanted to highlight is about IPD also. Well, to be more present in IPD. It's true that due to loss to follow-up, you had some late-stage patient arriving in directly in IPD, or due to lack of information, for instance, in Yemen.
There was, yes, you want to fill in, Cecile, yeah, to comment also, so, yeah. And then
Just, I'm Cecilia, I'm the HIV/TB advisor for OCBA. So just to complement on that question, it is a 40% of missing children. Among that 40%, most of them were dead rather than lost to follow-up. And one of the things that I think should be raised after this presentation is most of these settings, there is not access to early infant diagnosis, neither to viral load. So when we started implementing these activities, most of the children were tested with rapid tests if there were suspicions. The other point is that most of these kids were found in the crannies, so in the therapeutic feeding centers or in the IPD, and they were very sick patients with high mortality rates. And I think one of the recommendations after this evaluation, and that has changed our operations, is to focus more on pediatric projects and to tackle those children before they came to us very sick. I think these are the main explanations for these settings.
thank you. There's two more questions. We'll take them and then to see. Yeah.
Yes, good morning. My name is Philippe Sudre. I'm a member of the Swiss board. Just a point of clarification, but before I ask, thank you very much for the very dense and intense presentation and very short. The question is, you always talk about TB, HIV, TB, and I wonder if you can elaborate a little bit. Was it always both TB and HIV program, or was it sometime only HIV? And you really talk mainly about HIV, and it was almost always TB, HIV project, if I understand well.
Yeah, I'm sorry, but due to the constraints of time, I've chosen not to elaborate on TB because I didn't have enough time to talk about this. And the other thing also is because it has been more difficult to move forward for MSF on TB. And TB was run by the MOH in South Sudan, in Yemen, I mean in CAR also, and MSF arrived more to support the program, but it has been quite difficult. So, I mean, I had no time, well, not enough time to debate, and especially it was very, the situation was very different in each country, so it needed to be one specific case in each.
But it is clear that it's also part of this strategy to integrate TB and HIV, and maybe we will come back to it in the panel, I think.
Yeah.
Miss, you wanted to ask a question quick, and then we need to move on, actually. Yeah.
Is it working? Yes. So, thank you. I wanted to just to ask about the last slide, in fact, where you make the link to the 1990. And so I just wanted to have clarification that if we speak about integration, is it mainly HIV/TB, or is it also integration in other health services? Because our experience in the low prevalence countries where there is little attention for HIV patients, and as you say, competing priorities, it is very difficult to do, to provide correct quality services, accessible services, if you just integrate it in existing services that are weak, difficult to access, very burdensome for the patients. And on the support for the peers, it is often very difficult to organize that for small numbers. So in a way, so I wondered if you had also made comparisons with other type of models of care where there is not so much this integrated model that is proposed.
Yeah, no, we didn't do any comparison. No, we really focused in the four, but we can, maybe you
I
can.
think because what we actually mean by integration and how we integrate, I think will be one of the issues that we need to discuss further also in the panel. So we keep that question for the next hour, if that's okay. And there's a short question from the field also, so, and then we will move on after that.
Yeah, there is a question from François Dirmed of OCBA. You made a statement in the presentation regarding insecurity that should not be seen as cost saving. And he thought it was a very interesting concept. Was it an observation, a conclusion from the interviews, or a recommendation? That was the question.
Yeah. Let's say it was a conclusion of effectiveness, of efficiency, sorry.
Okay.
According to children, maybe we can go more in depth on the second hour.
Mm-hmm. Thank you so much, Geraldine. I think another report for the questions. So now we've covered two quite different but still operational implementation of HIV in different settings. Another strategic area for MSF has, I mean, for a long time been and is still to ensure access to low-cost treatment and also diagnostic tools to work towards that. And in that sense, we have had funding support from UNITAD for over some years to support that. And in last year or the year before last, there was an evaluation done on this support. Not the full scope, but really looking at how is it affecting MSF and how is MSF affecting the type of support. And for this, we have the very evaluator of this evaluation, Nicole Hense, who will give us insight into this.
Good morning. As already mentioned, the key aspect of this evaluation was not to look at the implementation of routine viral load monitoring in the different countries where this was implemented, but it was to look at the collaboration between MSF and UNITAID. What are the added value, the benefits, the risks, and the challenges of this collaboration? Underlying this, there was a freeze that was decided by the MedOp platform in 2014 to not go for any further UNITAID grants until there is more information on UNITAID as a donor and on the effects of this relationship for MSF. So very clearly different than the other evaluations. There is not going to be any implementation aspects from country officers. For those who don't know, a bit of information on the grant this evaluation is based on. It's a diagnostic tool grant on routine viral load monitoring, on point-of-care machines, and also on dried blood spot testing to be integrated as regular tool for patients on ART. This grant is led by OCB in collaboration with OCG and OCP as implementing partners, and also the Access Campaign receives funding through this grant. It is implemented over 9 countries and has a value of a little more than $28 million. MSF holds 2 further grants with UNITAID. One of them is on hepatitis C and the other one is on TB. They run over a variety of years, and the total value that MSF the total financial value that MSF is getting from Unitate over 7 years, 2013 to 2019, is about 63 million US. The collaboration between MSF and Unitate represents quite some novelties for MSF. First of all, this is the viral load grant is the first grant that MSF holds with Unitate. Unitate is a very new donor. It was only founded in 2006, and the other big difference and novelty is how this grant is administered and implemented. There is a variety, not only a variety of operational centers involved, but also other MSF entities, the Access Campaign, Manson Unit, Epicentre. Then there are also other research institutions that are tied into the grant, not so much for the viral load grant, but for the for the hepatitis C and the TB grant. Key findings: the grant has enabled MSF to implement routine viral load monitoring at larger scale and scope. In certain projects, this activity was planned already, but it would have been much smaller, and that focus across project has been viewed as very beneficial. Within MSF, it has as well contributed to shift the perception of viral load monitoring as something innovative and new that's done here and there, to the understanding that this is going to be routine and a necessary aspect of treating HIV/AIDS. In some countries, there was a much more formal relationship being established with MOH as a result of the grant's requirements, and that has as well had a very positive aspect on MSF's work in the sector of HIV in these countries. MSF has as well been able to contribute to best practice and policies, and a lot of the work of this grant has contributed to this. Unitate has not changed MSF's operational decisions or priorities. Contrary, despite a lot of work to get to this point, Unitate has proven very flexible and has allowed a lot of changes to the initial grant agreement. I already mentioned Unitate has provided a structured focus on viral load testing across operational centers, not only in the implementation of these activities, but also with regard to research. It has created the need for dedicated staff. There is a Unitate pool that helps to administer and manage the grant, that supports reporting, that keeps liaison with Unitate, that manages all the changes to the grants that they get approved. And it has required a significantly larger investment of MSF to actually get the grant. The processes are long and complicated to put together a proposal, not only because of Unitate's requirements, but also because of the unusual setup of several operational centers and MSF entities working together and need to come to an agreement on specific objectives and how this is going to work out. So that's very different for MSF than other donors. MSF has been able to influence Unitate as a grantee. That has been on content of the grant as well as on practical administrative issues with regards to grant management. Prior to MSF being a grantee, MSF was a member to the board of Unitate, and at that level MSF has as well been able to contribute to funding decisions that are in the favor of MSF. For example, Unitate funds the medicine patent pool. On the relationship between MSF and UNITAID, there are shared common objectives, but huge differences at the same time between the two. For MSF, as I've already pointed out, it is a long and laborsome and intensive process to actually get a proposal together and then again to get the grant agreement signed. If you ask UNITAID, they really like working with MSF, but for them as well, MSF is their most dynamic partner in very diplomatic terms. So for them, it's a lot of work. They have usually different partners that are used to work with UN-style donors with all the requirements, and that are also used to multi-year and multi-country grants. So it's on both sides that a lot of work has been done to come together and get a good working relationship going. Also, UNITAID is a new donor, so in the beginning, surely there weren't even guidelines or there was contradictory information given to MSF on what needs to be done, and also response times were very, very long, which makes it not very easy to move forward. The recommendations of the evaluations, I'm only going to focus on the general ones. The freeze, I'm not sure it's been lifted or not. Since the evaluation, there has been no UNITAID grant, but the evaluation has found no reason to not take further money from UNITAID in case there is an interesting proposal. A formal discussion about that should, however, happen at the relevant level. Furthermore, maybe for other work in HIV/TB, but also beyond that, the project management model that has been implemented for the viral load grant, that's also part of the hepatitis C and the TB grant, that has been proven very valuable, highly appreciated by those working on the grant at field level. And that's maybe something that can be taken further to be examined, if that could be a model that might allow MSF to work together over a variety of entities on a common objective. Thank you.
I think that we will come back to the discussion on whether we should take these type of grants, yes or no. But are there more specific questions to the evaluator who is here now? Please go ahead. No? Okay, then thank you so much. So we have been listening to presentations around should MSF be working in a low prevalence country and how is it feasible. We've looked at the rollout or decentralization integration into a number of countries going through conflicts. We've looked at the funding process on particular projects, and now we will have the last presentation on a project in a very, very high prevalence situation in the Homa Bay area of Kenya, where MSF France were doing a real-time evaluation at the same time as the project was rolled out. And for this one, we do not have the evaluator here, who is Monique Leticia, but we have Pierre, and now we'll see if I can say it as well, Mendiara, who is the Deputy Operation Director, and I think we'll also be able to give that perspective of, so what did we actually do with the findings, and what did it lead to? Did it lead to changes in the operational strategy? Welcome.
Thank you. So it's changing on the screen, but not on the screen.
That's it, yeah.
Okay. So the HIV and DWAP project. So I will first present the project quickly and the context in which it's happening, and after I will present the evaluation, and I will say to which discussion actually the evaluation led. The general objective of the HIV and DWAP project is to reduce the incidence, morbidity, and mortality related to HIV and DWAP sub-county 200,000 people more or less, and Homa Bay hospital, so hospital for the whole province and not only for the sub-county of Ndiwa, through an integrated, complementary and simplified model of care. So the integrated means MSF integrated in MOH structures. Complementary means only to complement what was already provided by MOH or others, and simplified model of care is just the model of care specific to HIV to try to make it more simple. So a subtitle could be aiming at 1990, and it was written like this in the project, to reduce incidence by 50% within 4 years. And the activities, the main activities put in place to achieve these objectives were testing and circumcision campaigns. So since then, the circumcision campaigns have been abandoned because they were not working. They were targeting at adults more than 30 years old mainly, and it was just not working. Decentralization of care and treatment, the furthest possible in the countryside. Access to viral load testing. Support to adult IPD in Homa Bay and Ndiwa hospitals, although this is not actually contributing to the global objective of 1990 or reducing incidence, still it was considered important to have this activity to bring hospital care. And the model of management of the project was a strong and binding coordination with MOH and other partners. It started in April 2014. So for understanding of the rationale of the project, the HIV context was a prevalence of 24% and an incidence of 1.3% among men, 2.7% among women. This was shown by an epicenter study done at the end of 2012. So it's a high prevalence, it's a high incidence. And regarding the IPD in Homa Bay Hospital, we have found a little bit later when we started the project, we did a specific study that the mortality in the ward, adult ward, was 14%, and even higher if you consider the immediate post-discharge mortality. I think it was rising to 22% within the 3 months after discharge. And for the cascade of intervention, before intervention, so we can see that the main gap in the cascade before intervention was that the percentage of people diagnosed among the total population of HIV positive was low, 60% only. After, they already had actually quite a good linkage to care and quite...
Oh, no, it doesn't. That's strange.
Oh, okay.
I can see it here, but...
Yeah, it's moving here, but not there.
That's weird.
It was clear, no? Anyway.
Close and open, maybe?
Which one is it? Is this one?
I think it's not a big deal anyway because it's the same thing. But
Where is it? It changes here.
Yeah, close
No.
it down.
The PowerPoint.
Maybe you can continue speaking if you want to now. Try and work on this.
Okay, but,
If you remember what you said.
yeah, I was saying.
Yes.
Oh.
Okay. Thank you. So I move with that.
The arrows.
So they actually, they were very low in diagnosing, but they were quite good already in linkage to care and putting under ART. And after, there was still an important gap is about for the proportion of patients under ART who are actually who have an undetectable viral load. Okay, so the midterm evaluation had as a general objective to realize an evaluation of the ongoing Ndiwa project regarding the overall operational strategies and particularly regarding the joint management approaches and strategies for sustainability and replicability. The two bigger aspects of this approach for sustainability was first a very formal and binding steering committee between MOH and other partners that was meeting every 3 months to actually take important decisions on the program, and technical working groups with the same people on specific aspects of the project to feed the discussion at the steering committee. And the other trick was that all the staff actually in direct contact with the patients was MOH staff. So the MSF has funded MOH to recruit additional staff, quite a lot, actually 200 after 2 years. But it's not MSF staff, and MSF has deployed a team of mentors that do supervision, training, and participate in the decision for protocols. So the evaluation was done by Monique Latelise, Patricia Convent, and Vincent Brown. So as a third result, actually, I bring it from another study that happened more or less in the same time. There's been a study specifically on the population of pregnant and breastfeeding women, which has shown that actually the scale-up seems to be happening, because for this particular population, we have reached the 1990 has been reached already. We are above these results, and even the undetectable proportion of patients is above 80%, which is not bad. So, but of course, it's for this particular population, which is easier to catch, for example, than the general population and the men in particular. And to note as well that the same study showed that, in fact, the incidence did not decrease, maybe even increased a little bit. It was 4.1%. So some results and recommendations of the evaluation, so very few given the time constraint. Overall, the partnership is efficient to achieve broadly the results, and they have pointed at as key factors for being an efficient partnership is the fact that first, there was a good knowledge of MSF in OMABE and of OMABE by MSF, given the anteriority of the presence of MSF in the county. The second aspect was that the management staff of the project have stayed very long time. For example, the PC is the same PC since the beginning of the project, 3 years almost now. And as well, the fact that just before the project, in fact, they have put a federalist devolution system in Kenya, and in fact, the decision taker for everything regarding health in Ndiwa is taken in OMABE. So you talk to people who have the power, actually, in the steering committee. The technical working group didn't work so well. But we have seen a persistent high mortality in the OMABE IPD. I think I forgot to say it before, but it was evaluated to 30%, and almost 2 years after the beginning of the project, the mortality was still 14%. So the recommendation actually have pointed at a need for improvement of management of acute cases. 37% of the people who die in the first 24 hours. So better triage, better management of acute cases, and in fact, better understanding as well of late arrivals, therefore reaching to recommendation of more investment in the IPD. The other recommendation, they told us to be aware of the level of investment by MSF, because there was maybe a contradiction between what was supposed to be a lighter approach to facilitate a future handover and the reality of the investment, and to be realistic with the UNAIDS 1990 objective. I will come to that later. And there was as well something that was not developed at all, but led to a lot of discussion afterwards, which is that we should develop the counseling practices towards the real population health education. So actually, the discussions that rise from this evaluation, the Be Realistic was in fact pointing at at the fact that the hypothesis, the main rationale for the project is actually a purely theoretical hypothesis, science-based but not reality-based, which is to say, first, it's possible to reach 90-90-90 at a population level, and supposedly on a sustainable way, and that reaching 90-90-90 will lead to a decrease in incidence. Bon. So if you look at this hypothesis closer, first, you easily understand that reaching 90-90-90 would suppose extremely strong self-discipline at a personal level and at a population level in Andiwa. Is this realistic? And for the hypothesis that it will lead to a change in incidence, well, there are also factors that could explain that, in fact, it's not sufficient to bring a decrease in incidence, and particularly, for example, if the incidence is happening, the transmission is happening particularly right after the contamination of a patient. And this is maybe what is happening with the populations that we have seen before, where the incidence stay high among breastfeeding and pregnant women. And also, maybe there are other factors that we don't understand that explain this high prevalence, high incidence in Andiwa, like, for example, genetics factors. And the question has been as well on the haven't we been given too much priority on the public health theory and objectives versus a patient-centered care? So here as well, at least, I mean, compared with other HIV projects in OCP, at least, we have a hospital care component, but after all, it was not so much developed, and the light approach is maybe not so much adapted to reducing mortality in a hospital like the one of Homa Bay. And to finish, the recommendation of we should go towards a real population health education has brought a lot of discussion about what is actually our discourse, what do we transmit when we talk about our project, when we talk about to the authorities, and especially in the counseling sessions that are, as you know, a big part of the HIV programs. Because in fact, there have been always in Homa Bay a discussion about a supposedly extremely intense sexual life of the inhabitants of Andiwa, or the Luo in general, and this sexual life which partly derived from some traditional habits in the population has been documented a lot for the Luo population in general that live in this place. So, do we actually, in our counseling session, should we, and do we already try to impulse some behavior change regarding sexuality based on maybe culturalist lecture of the situation in Andiwa or not? Well, we have not gone through the whole discussion, but it's really something that everybody has a different opinion on. In fact, from the field to the headquarters, about what do we do, what do we say really in the counseling sessions today? It's not so clear. And after, what should we say regarding sexuality or not say? So this was the right questions. Thank you.
Thanks so much. While I ask the panel to get ready, maybe you can sort of take a few questions as the presenter of the evaluation, and then you will move over to be at the panel. Is that okay? So are there any questions on the evaluation? Yes, Annick. And I'm asked to talk into the microphone. Can you? Yeah, I hope.
Thank you very much for a very interesting presentation. I wonder if incidence is seemingly not lowering, is it the truth incidence, or is there issues also on measuring the incidence? I mean, are you very sure that the incidence is not going down?
There are probably issues on measuring the incidence, but I trust the work of Epicent. They were quite confident with it. But it was not overall, it was really among pregnant and breastfeeding women, which are 23 years old on average, if I remember well. And we had seen in the first population study that actually this is a population where the incidence is the highest. They are the most affected by the transmission of HIV. The young woman between 14 and 24 years old is passing from almost nothing as percentage to 25% in 10 years. So maybe we will see for the general population, maybe there is a decrease in incidence. We will repeat NIPS, the population study in 2018, to see if the project achieved some results or not. So maybe in the general population, we will have a better result, and this is only after 2 years as well, so it might be a binding point later.
Okay, one more question, and there's anything? Yeah, okay, so one there and one from the audience who are streaming in also.
I just have one comment on the behavior change mechanism. Do you think counseling was just enough to tackle behavior change, or did you have any activities that you plan to do outside of the counseling rooms in terms of community?
So there was a big community mobilization component in the program, not only in the counseling sessions for HIV patients, but as well because there are some testing, circumcision and at the beginning and now only, but still remaining testing campaigns with a door-to-door strategy. So actually, it's a very invasive strategy that consists in going to every house of the county and to talk about HIV in the pre-counseling session, etc. So yes, and this has gone with as well some preparation, communication. So I would say, yeah, that there were other stuff than just the counseling session. In overall, a place where the acceptance of HIV testing and is extremely high. Like, for example, when they did population survey, 91% of population of people proposed, accepted to be tested, and is still what we see in the door-to-door campaign. And regarding stigma as well, we could say that stigma is quite low, although not so low for everybody.
Thank you. I think we will move over to the panel now, actually, and if there, I mean, you can still come back with questions on related to these evaluations or presentations, of course, because that's what we're discussing here.
Annelie?
Yes?
Just a message for those following us via streaming, because I have a little problem with the chat. So the questions we got in, they will be in the debate. We have them. And if you have more questions, email me right now.
Yes, and we will try to read them out as questions during. Okay, so we do have 6 people in this panel here for the next hour. Well, one of them up there is David Maman, who is working for Epicentre and who is based in Cape Town and who will be with us over video conference to also give input and answer questions. Pierre, you already know. We also have Tom Ellman, heading the SAMU in South Africa. We have Cecilia Ferreira, who is the lead of the HIV-TB working group and also working in OCPA as HIV referent. Christian Katze, who is the desk or the operational manager for Central African Republic for OCA, based in Berlin. And last but not least, we have Alexandra Kalmi, who worked for many years as the referent for HIV in Geneva or in OCG, but who is now working at the Geneva University Hospital, also in relation to or leading HIV there. And so you have sort of the inside and the outside perspective to this. Now, I mean, I think when you listen to the presentation, sometimes they tend to give you more questions than answers, I guess. And I'm sure that there's a lot of questions that was raised here that we could, of course, discuss around that. But what we also have asked the panel to think about and to try to frame here is, what are the take-home messages? What would you like to take away from this session in terms of the presentations? Are we actually moving into a new era, or are we struggling still to implement the strategies that we set out to start 4 years ago? I mean, where are we in this, and what do you see as coming next? What's the next steps? And I'm not going to ask you to present one after the other, but we'll start with one of you, have the audience coming in, and then we'll move along. And I'll try to make sure that everybody has time to speak and that you also have time to intervene and ask questions or make statements. So should we perhaps ask Cecilia to give your reflections first then?
Okay. I have two hats today. So I'm the leader of the AIDS working group, but I am also the HIV/TB referent for OCBA. So I'm wearing two hats. I think that the main bullet points that I would like to share about the 4 evaluations that has been presented are going to be under the hat of the AIDS working group. I think these 4 evaluations are fully in line with what has been defined as a strategic framework with the endorsement from DIRMEDS and DIROPS for the last 4 years. And this strategic framework is about to expire by 2017. So it's a golden moment also for all of us to redefine what will be the priorities for the following 4 years. So what I see a line in between the 4 presentations, low prevalence countries, now we call it Western and Central African countries, some of them conflict-affected countries. Are they, how was the title of your presentation? Should we bother about or not? And our answer is yes, this is one of our main priorities. But one of our main concerns is how to make it real, how to fill the 1990s in those settings with innovative strategies. So I think this is something that will come because we don't have yet the answer. From the UNITED proposal, the UNITED evaluation, I think is an excellent lesson learned for all of us. They show MSF as a movement that routine viral load is not a luxury, it is a right, and it's a standard by the quality of care for patients who are under ART. And I think this evaluation shows that we could work again with another proposal or with another donor. About the integration evaluation, I won't say that much because I will feel biased, but I think it's an excellent example of what can be done in some settings. But again, with the dilemma of peer, that should we tackle the epidemic and be a public health approach, or should we be target-based approach? And I think that here is very healthy, the exercise that between all OCs, we find complementarity of we can do this and you can do that, and we can go further on this. And I will stop here, otherwise I think I will not let Tom enough time to talk about.
Anyone in the audience who wants to react to Cecilia's first notions on this? No. So maybe, yes, Mercedes.
Yeah, so I'm Mercedes. I'm the International Medical Secretary for MSF. And just to hit a little bit the debate, the 90-90-90, fine. What about the 10-10-10? Just that I would like to get your takes on that. Thank you.
Puts things into perspective, yes. Alexandra?
Yeah, it's a kind of answer to what you raised, but also something that came out in my mind after listening to these 4 evaluations, especially the one from Guinea on decentralization and the one from Kenya. It seems that what these 2 evaluations have shown is the need for the decentralization, getting as far as we can into simplification, decentralization, and 1990, you know, in this very difficult to reach area. And what has been shown in Homa Bay in Kenya is that you still have 13% mortality in IPD. So you have the whole continuum of care that has been presented in these 2 evaluations. And that for me was very interesting because exactly as you said, you cannot think that the 90 means the 10 are not accessing the care. That's one thing that MSF is addressing very well, but also 10% are failing treatment. And failing treatment means not only having a new genotype and change the second line, but also mean that they have difficult to treat opportunistic diseases and that those people are dying. And I think all express the difficulty for referral. You mentioned in Guinea the need for referral that would be key for the decentralization, because of course, if you have no referral, it's difficult to decentralize. And also, but then when you decentralize and you put them in the hospital, they die. And in Maputo, where I was with Alex last week, what we see that the MSF team is trying the best for not to refer to the hospital. And they even have invented or put in place a kind of intermediate model of treating patients in an intermediate MSF-led structure that is not primary health care, but is not IPD. And I don't know the answer about the 10-10-10, but clearly that was a way of answering how to treat this difficult care, these difficult, vulnerable patients. And that also leads for me to the discussion about what is the target population, what is a vulnerable patient? Is it someone that is difficult to reach? Question of access that is defined in your strategic framework. You want to go where the others are not going, tackle difficult to reach population. But I would want to propose maybe a discussion about what is really a vulnerable patient. And maybe that's the 10-10-10 that you are mentioning, not only the 10 that you do not access, but the 10 that are failing. And that means a different way of treating patients, not only tender love and care. I didn't know this, this expression that you mentioned in your evaluation, but quality of care, how to reinvent a model of care that maybe gets rid of hospitalization, maybe not, but in any case, needs to be thought about what is a good quality of care for the unstable patient, sickest patient. And those ones may be the next target that we have to tackle in the next generation HIV programs.
Christian, you want to fill in?
I mean, when you ask what to take away from the presentations and looking from reality, especially in Central African Republic, where we are looking at Zemio, so a place quite remote, and how to get care there. I'm not sure whether we discuss at the right level or whether we are actually too academic, and we have not found the model of implementing, care. Yet. I've not seen that in MSF, where we address the low prevalence, the high insecure, combined, with the low cost things. And that's what I take a bit away from some of the presentations, where I think, we come with a huge machine. And I think from being non-medical, we found quite some medical answers to how to treat opportunistic infections, second-line care, et cetera, and we come with a big machine. There is no answer yet how to do that in a setting where we are not willing to expand and expand so much as we would have to in order to address some of these needs. And I think that's the answers we have to find today. And I think that's for me still missing in our ambitions also. How to run a program in this setting where we have 1,500 patients on ARVs, most of them on first line still. In a setting where we are not willing to run general healthcare because the number of population in general is too small. Nevertheless, we would like to stay engaged with that population, and I think that's the answers we have to find if we want to move forward. I think as an organization, we found ways to treat in South Africa. We found doing Zimbabwe, Swaziland, some of those places. you know, it's more a medical answer than an operational answer. And I think where we have to get better is the operational answer. That's we completely miss, and that's what I would be interested in terms of discussion, how to move that forward.
Thank you. Reactions to that? I think we'll then leave the floor to Tom to continue that, and then we'll start up more of a discussion ending.
I've had all this time to think, but I can't because I'm being distracted by this picture of my beautiful colleague David in front
He's
of me.
here, you can feel it.
I'm sure it's airbrushed.
Yes.
So I mean, we'll talk more about the 10-10-10, and I think two of these presentations, these evaluations really speak to that, both in terms of countries where the 90-90 are the 10, the whole population, but also in the hospitals where we're seeing the people, the result of our failures to give access to people early enough from populations that are not presenting. But I just wanted to give another reflection on this end of an era. I think HIV has always been something that has shed a light on how we work in MSF. It's provoked what we do. And I think that there are in many ways in which we are reaching an end of an era in humanitarianism and in HIV, and we need to think again about what we're doing. And we're not here to discuss the process of these evaluations, but it does raise the question. We have scientific days, we have operational research days, we have field visit reports, we have evaluations, all of which are trying to make us an evidence-based organization rather than a faith-based organization. I liked your alternative facts. In an era of alternative facts, how are we going to understand the value of what we do and how to improve it? In our scientific days, we tend to focus in detail on a question. We come up with some research question that we answer, and we try then to think of what are the broader implications of that. Whereas here, we start with a very broad view of a project, and sometimes we struggle, and I struggle a bit, to say what is the practical, specific issue that we should bring out of it. So I just wanted to look at another of those presentations, the UNITAID discussion, which does speak to a very practical and broad operational question about institutional funding. I'm sure we'll have some more chance to debate that. But it's very interesting. The interviews were primarily with people who were from the medical side. I didn't see any general directors, for example, who were interviewed. Maybe I'm wrong, but I looked through the list. And we know there is a real contradiction between a recognition that institutional funding brings added value in terms of driving institutions to pick up, in this case, viral load, working on hepatitis C. We're now in discussion about self-testing for HIV, all things which in our projects we want to do, but we also want to drive a change in access and the landscape, versus the dangers that institutional funding bring when we need to be perceived as completely independent of power. And certainly in OCB, this is a very live discussion where there are strong voices which are not represented in this evaluation, but will impact on whether or not we decide to continue with groups like UNITAID, which say HIV might need to be collateral damage. We're going to have to accept that if we accept any institutional funding, it might compromise our access in certain contexts. And we're not willing, even though the UNITAID funding might benefit HIV, we're not willing to compromise because of the impact that has elsewhere. And I think this is, right now, we need to look at some new UNITAID opportunities and broader ones. So I like that presentation as something that forces the reflection, but I missed a little bit the counterpoint to accepting funding for one disease in one area with a valuable impact, and what that means for our broader humanitarian access questions.
So that's a broad field of questions and topics for debates already. Low prevalence countries, yes, we need to go ahead, but where are the right strategies? How do we do that? Why do we not invest more in the last 10%? Why do we not work more in actual hospital care and trying to treat the ones that are at a very high risk of dying? Shouldn't we be there more? Are we there to handle the epidemic or the most vulnerables? What about the medical medical questions in relation to the humanitarians, independence as a humanitarian organization, but the actual medical possibility to do more for people, for the people in relation to HIV/AIDS, and how do we make these big projects function? I think we start with that, and then we ask David and Pierre to come in a little bit. Is that okay? Because I think there are several hands up already, and there's also input from the streaming participants. But someone here already? Oh no, I saw hands before, but maybe they went down. Yeah.
I'm Christine, I'm the new Director of Operation of OCG. I will just come back to the 310, and I would like to add 100% in top of the 390, because we are focusing on the sick people, but what are we doing for the one to remain negative? And I'm really wondering how we could as well engage with regard to maintaining negative people negative, and we are not at all active on this perspective. That could have an impact as well on the remaining 10.
I'm Apostolos from Athens office. Anneli, you raised in the beginning the issue of the people on the move or the people being stranded, because we don't talk anymore people on the move, we have also stranded. And I think the context we're facing and discussing for many years in MSF is how to approach the issue of HIV, TB, hepatitis C, I mean, for these people, and especially also in a reality that we're being seeing that access and accessibility, even in European setting, it is a problem with almost zero access, especially in the countries sometimes that the access and accessibility is problematic also for the people of the country itself due to the economical crisis. And I think on the issue of the people on the move and stranded is something that we need to bring it back. There are experience of Musina project in the past, and I think we need to be a bit more proactive on that. And I think working inside of Europe with that issue, in addition to other problematics, is something that we need to consider.
We have a few questions from people that are streaming in. One is from the medical director of OCPA. Now I haven't read through before, but in an era of MSF addressing more complex health needs in an increasing proportion of projects around the globe, shouldn't the new era for HIV go beyond HIV itself, as also considering other prevalent chronic communicable diseases such as hepatitis and others in that area? Is this under consideration, and what are the panel's thoughts on that? So should we also increase the scope to other non-communicable or chronic communicable diseases while we are debating around how to move forward with HIV? Cecilia and Alexandra wants to come in.
I will be short. I mean, it's trying to address Christine's comments on how to stay negative, because I think it's absolutely key. It's not even getting to the 90, it's before the 90. And what I think is very interesting is that being HIV negative is a diagnosis. Being HIV positive is a diagnostic, but being HIV negative is also a diagnosis. It's something that we use counselors to announce the result. And I think this is something we have to address. And especially now, I thought there was a kind of a white elephant in this room because we didn't address the PrEP. And when listening to what you presented with a very high incidence of HIV infection in young female, and I think it's also very much seen in the southern part of South Africa, I think the new era may be not only to treat HIV, but to treat people to remain HIV-free. Whether this is the PrEP or whether this is the harm reduction for IVDU in some settings. I don't want to always mention Mozambique, but I know it's also something that is to be considered. That are at least approaches that I think should be on the top now of the scene, because PrEP exists. It is very efficient, And we know the target population in many of the, it may be, this target population are very different across the countries, but you know your population very well, so you're very much able to know who can benefit from the PrEP. But these are the very complex new questions, of course, and I'm very well aware that we haven't answered all the questions regarding the PrEP, but at least I think that would answer to this, how can we help people to remain HIV negative? And that will also be part of the question of controlling the epidemic, of course. And the second point, and I will also be very short, is about the other communicable disease. Of course, I'm not MSF now, so it's not me to answer that. But what I would like to say is that HIV set the scene. It's possible to treat a chronic disease. There are many challenges. We don't know how to answer all the questions. These questions are debated now, but still, it set the scene. We take the blood pressure for HIV-positive patients. We know that they might have more diabetes or stroke than other populations. So we know that we can treat those populations and we can do chronic disease management also in conflict settings or in emergency, and that was shown by the evaluation. So yeah, I think that would be probably the next coming interest in MSF, knowing that we are even treating Kaposi sarcoma already with chemotherapy, so we certainly are able to expand. But until where and how, that's a question that operational center have to answer.
We can, but should we? You want to include something, Cecilia, or yes?
Yeah, just regarding the integration, whether the new era should take into account other chronic diseases or other diseases, I think this is something that we are already doing. There are already some sections that has been tackling chronic diseases within HIV programs for 10 years, more or less. I think that what we are looking for the new era is integrating HIV, but according to the setting where you are, and we don't want to come up with fixed packages that then are difficult for the field teams to swallow and difficult for operations to understand as well. So what we are trying to push is you need to integrate HIV care, and you have to look at your epidemic profile in the setting where you are. So I won't give you a package of chronic diseases, hepatitis C, HIV, for Batangafo in CAR, for example, because maybe that this is not your main killers. HIV, it is one of the main killers in CAR, but most probably it's going to be related with malaria, with vaccination, and with decentralized packages of care. And most probably this is a place where you have to go for test and treat with outreach communities and getting outside of the health facilities. So I think what we need to define in the following framework that we need to start working right now in the following framework is that we need to have flexible packages for flexible interventions according to the settings where you are. And getting back to what Alexandra is saying, I think that prevention has been a word that we have tried to avoid several years within MSF. There has been discussions whether is this the role of MSF or not. Now I think there is a consensus that yes, it is a role for MSF, prevention in all the means. Some OCs are doing more than others. Even PMTCT is a prevention strategy that we are still quite far from what we would like to do. So this will still remain a priority for the following years. Key populations will remain a priority for the following years. We are learning with some projects with drug users, with prisoners. We are trying to set up MSM packages in Yemen in the HIV vertical project. So there are some of the things that are on the table that has already been worked out, but definitely the new era needs to be more provocative, let's say, and more adapted to the settings where we are working now.
I think you even have to take it a step further, because I think from an operational perspective, really, I think we tend to put too much into our ambition. So we get too head heavy and we forget to walk. And then when we push that head heavy individuum, it's falling over. And I think that's, we see over and over. From where I sit, I really would argue to to maintain, to stay with one ambition and try to see how you implement it and then slowly add, rather than, add things on a white table and then asking teams to implement where we would fail, because in the end we will end up again with huge programs which are not based anywhere into reality, and we will end up again with then the evaluations on trying to decentralize and having low cost and light models, which I think that's where, if you want to sustainability, you should start with, and not build a big program and trying then to boil it down. We never manage that, and I think that's the big challenge we have.
So, not too head heavy. We have to work, okay? And I think we should let the last two panelists in before we continue the discussion. We have some questions from the Zimbabwe mission on sustainability and on how to do it also. But maybe, David, if you are able, you've been having the chance to not only to listen to the evaluations, but also to part of the discussion. So maybe you can come in also with views on what has been said by the other panelists here.
Yeah, thank you very much. So I think in MSF there is a shift today in our operation, and this shift is due to one simple thing, is that in Southern and Eastern Africa, coverage is increasing, as it has been shown recently by the studies that have been done at national level in Malawi and Zimbabwe. Countries are getting closer. These countries are getting closer to the 1990. So the needs for us to support this project is less important today in the same way we were doing it. So basically, we have 4 new kind of operations that are developing today. It's like going to countries with low coverage, like Central African Republic, West Africa in general. Nigeria should be a focus soon. Moving towards key populations, like is done very well by OCA in Myanmar or in India, like is done with sex worker by OCB in Mozambique, or fishermen by the French in Uganda. The next thing is prevention. You can see a rise in prevention projects, especially PrEP with Swaziland, with South Africa coming, with Kenya, Mozambique. So this is a very strong area of action for MSF. And finally, advanced patient and especially hospital care, where there is absolutely zero funding coming. So you can see an attention going towards there with the projects of Omabe and the project of Kinshasa. And especially because in MSF we don't have so many projects of adult medical care actually. So it's also an interest of MSF. So I think this is the 4 areas where you can see a movement of MSF today.
Thank you, David. Pierre, you were part of presenting, but you're also part of having views on all of what has been said here.
Regarding the choices that we have to do for operational decisions, well, we have the opportunity in MSF, we have the chance that among all sections, we have the means to develop operation both in high prevalence setting, low prevalence setting, operational research, hospital settings, public health strategies to curb the incidence, for example, and a lot of operational research with new models of care in general. So the question is, as we can do everything, let's continue to do everything, but at one stage we have to make choices to where do we invest most. And for this, I think one of the avenues should still be the classic one of mortality, and where do people die most of HIV. It seems obvious, but in fact, I think that with the technicity and the specialties of in particular trying to improve the models of care and the research in general in HIV, maybe we have been sometimes forgetting this strategy, this objective. At one stage, like 2-3 years ago, we had to make some choices because, for example, in OCP, we have the sense that given the means that and the priority we want to give to HIV regarding the whole portfolio, we can have between 4 and 6, let's say, vertical or with a high priority to HIV projects. So if we wanted to make choices, for example, we arrived to some basic dilemma to choose between in Shirazulu, for example, where we are already achieved almost 1990. We could have continued in Shirazulu and tried to do smarter things, more technical things, like we can improve what we do for adolescents, we can improve what we do for men who are only at 80 instead of 90 and something for the woman, for example. But we have chosen to hand over this project by 2018, considering that we have added a lot of value already, and that now it would be more interesting to move where the HIV situation is much worse, and particularly not so much in low prevalence setting. Also, we open a GOMA project in a very low prevalence setting, between 1 and 2%. But as well in places, because there are places where in the same time the prevalence is quite high or even high, and the coverage of ART and testing is very low. I'm thinking about the south of Nigeria today, where you have on average between 8 and 10% prevalence. It's enormous, and extremely low coverage. So it's an objective, but for different reasons we have not been able still to open a project over there. We're still trying. Or we have decided to open a new project in Uganda regarding as the specific population. So we try to be smart as well regarding as the fishermen, fishing communities in the west of Uganda. And just to say that I think we should have always this objective in mind, rather than being brought too far in the general vision of the big public health institutions and global health institutions towards definite solutions. What I was talking before, yeah. So 1990 plus the 10-10-10. Bon.
Yeah. 10, well, yeah. 10, 19, but the 10 will be more than that.
They are in the hospital, the 10.
Yeah, that's
so
it.
They are the one we address in the hospital, I think.
Yes, Tom. Yeah.
I mean, there is a contradiction in this. Our focus on where and why do people die, I think, is an excellent starting point. It has always been clearly what drives us. And we know that people are dying primarily, I can be a bit, where MSF is not. So the question has always been, what is our impact beyond our programs? And you highlighted that in your presentation as well. So when we talked, one of the presenters talked about the importance of simplicity, keeping it as simple as possible to maximize both our own impact and our reach. We recognize that we have failed to use the most simple measures that are available now to ensure better access for sick and advanced patients. We're not using simple TB tests like LAM in our programs. We're not ensuring CRAG is available everywhere. We're not pushing as we could on identifying with CD4 tests, because we've been a bit distracted by viral load over the years to identify who is most at risk. But clearly, we have got to a much, much easier place in terms of delivering care than we were 10 or 15 years ago. It has been our greatest success by far. The most complex things now are about health systems. They're about why are health workers not paid, why are health workers not motivated, why is there no supervision, why is there no supply chain and supply system. And it's a bit unfortunate because it isn't where we want to be as MSF, but it is why integration outside of high prevalence areas has not succeeded. So there is a major question in terms of a new era of how willing are we to translate those experiences we have had in Southern Africa, where HIV is a priority, and therefore it was easier for us to impress on governments the need to invest into change, to get that same interest into the low coverage, low prevalence areas. And clearly, as I think Jean-François was asking, it must be about recognizing that you're only going to succeed with HIV if you succeed with an integrated approach with other diseases and the priorities of healthcare in those areas. And I think that our focus within MSF programs on integration, which was the subject of the OCBA evaluation, is very important, because even within our own programs we are failing. But actually, the real question is, what does that mean in terms of affecting a system where the staff are not there and they're not motivated and they're not engaged. However simple, we're able to develop the model for delivery of treatment.
There's actually a few questions coming from, two from the Zimbabwe mission, the OCA Zimbabwe mission, and one from Jean-François Soyer, the medical director of OCPA. And so from Zimbabwe, they are slightly related to this because it is about sustainability somehow. And one of the questions are, how pragmatic are we when we say free care for HIV patients? Because, for example, in Zimbabwe, MSF has been paying for HIV patients into the system. And now that we're pulling out, you know, it's very clear at the same time that the Ministry of Health does not have any money. So we say that we're a catalyst for change, but where are our projects actually leading? Also another one on the integration and collaboration, because how do you manage to collaborate with Minister of Health in data collection and still maintain quality data that can be used for making useful evaluations and for treatment outcomes? And then one more question, more on when we talk about the strategies, and we should be where people are either mostly affected, where they're dying. There's also from the medical director in OCPA, he wants to highlight that perhaps we should also be talking more about prevalence and incidence, and maybe we should focus more on where the incidence is the highest as an extra point. Annick, and then maybe some questions or answers also from the panel. Yeah.
So when it comes to low prevalence settings, I think we actually face exactly the same challenges with nearly no exception than when we started HIV in the high prevalence settings. It's always the same coming back. It's about getting the people, it's about attracting the people, about making them understand, it's about getting them on ART, it's about keeping them on ART, and it's about keeping them with a low viral load. The only difference is that you don't catch, or you seem not to catch as many as you did in South Africa or Swaziland, because the prevalence is, but it's exactly the same. Why can't we manage to translate all the lessons learned we have from all the experience with it in high prevalence study and try to translate it how to do it in low prevalence setting? We forget how much advocacy we needed to do inside the house and outside of the world to get to do all the things that we did in the Southern Africa. We forget our own lessons learned. And of course, I do understand that there are additional challenges in some of the countries. You have conflict area that doesn't help. You have health systems that are even worse off than the ones that they were in Mozambique, or where they were already pretty bad. But that doesn't mean that we can't take advantage of what we learned in the previous setting. Regarding mortality, just a short side, we tend to look only at mortality in our health structures. I think this is really not correct. All these ones that we lost, those 50% I mentioned there before in Guinea, there is a high percentage who died at home. We didn't see them. So I'm afraid, Tom, that I disagree with you. Even where MSF is there, people are still dying a lot from HIV. And maybe we need to concentrate on these ones first. And they will, I believe that the incidence does diminish when you have a better coverage. I don't know whether that's scientifically correct, but it seems to be logic. But I think if MSF starts a project, sustainability has always been a problem, and certainly not only on HIV, that would be ridiculous to think, but maybe we should really focus on retaining the ones we have in care as much as possible there where we are. Because we have taken these patients on, so it's on responsibility to follow them the best we can.
Thank you. Yeah.
Yeah. Another difference for the intervention in a low prevalence setting is comparatively additional means you have to put to diagnose an HIV positive person and then to put it under treatment, because you need to test more people to find one. And this raises the question of first, why to invest more in a particular place to get one patient than another, where you could get more patients in another place for the same investment. And as well, it raises the question of, are you fitting the biggest need of the population where you intervene? we do currently a vertical HIV program in Goma, we will see what result it's a very light approach as well, and we will see it started recently, so we will see what result we are able to achieve, and if we are able actually to launch a dynamic that will go beyond us, and the objective is actually for it to be integrated, but it raises as well the questions, are we in line with what are the needs of the people in Goma, or are we just doing something that is not so important for them and will rise to a problem of sustainability with MOH because it's not their priority? And I suppose that the answer to that might be that it should always be an integrated program in low prevalence setting, not only integrated within MOH, but integrated with other activities within the MSF project, maybe.
Cecilia, and then Alexandra also. Yeah.
I just would like to raise two things about the prevalence discussion and the incidence discussion. We have had this discussion for years, and particularly between medical departments and operations on whether to focus on high prevalence settings or places with higher incidence. And it's true that 15, 20 years ago, when we started working on HIV, that was the main priority because people was dying. So it was not a discussion. Yes, we go where the places are highly dense populated and there are more people dying of HIV and the prevalence is very, very high. The recent discussions that we have, and I think we have an agreement between the HIV reference and at the AIDS working group, but still it's not a consensus between all the OCs, especially with operations. What Tom says that people has access to ARTs if MSF is there. I think this is something to keep in mind. And what we are always, I wouldn't say criticizing, but when we are doing advocacy and lobby towards fundings and donors that they are giving up money because this is going to be the new era as well. Less money for HIV is the trend. These guys, they are focused on high prevalence settings in big cities and big burden places. So they will be already there. So I really see that we need to discuss further and not to do the same mistakes that we have done in the last 15 years. And as you mentioned as well, that there are a lot of lessons that we learned in these last 15 years. In the low prevalence settings, we should be smarter, maybe, than when we were in the other places, where we get stuck until here and we could not even hand over such big cohorts. I think that we have the experience enough to start quick projects and live faster. I think we know how to do easily a project with counseling, with decentralization, with community-based approach, and to hand it over in 3 years' time. I think we are now calling donors to go for those settings and to pay attention. But we need to be careful with the messages, because if we MSF are saying that we want to get focused only in high prevalence settings and only in high incidence settings, I think we are contradicting ourselves and getting the focus on those settings that they did not have attention for the last 15 years, which are the Western and Central African countries.
Alexandra, you want to react also? And perhaps on the well, it's partly on the questions also, of course.
It was partly on a reaction and partly not. Just jumping on that with Cecilia, that's not what I prefer to say, but for the low incidence country, I agree now, low prevalence and low incidence country. I think it's quite interesting because it's also the country that will not have the funding support of the Global Fund, for example, for whom the access to cheap treatment is more difficult. So there might be here a gap that MSF can fill, not only in terms of medical practice, but in advocacy. And I think it's important to be there if you want to be able to advocate for access to drugs, just on that. And I was just wondering about the incidence in KIPIC, the HIV negative free population. I was just wondering about the position of MSF for the gender violence, sexual violence, genital mutilation, all of this, because it seems to me that it's both contributes to the HIV incidence that is quite elevated in certain part of the southern Africa, and also to the difficulty and the stigma for these women to come and to access to care. I was just wondering, and also, of course, for the PrEP, because that's the key population for PrEP. So I was wondering whether that package could be altogether offering PrEP, but also targeting gender-based violence. And so that was more of a question and a comment than a response. And then I just wanted to say that from my perspective, there is something that is kind of a tension between the lessons learned since many years, and I see here many people in the room that share these lessons learned with us about treatment has to be free, it has to be simple, it has to be decentralized, it has to be task shift, and this contributed to the success of MSF in HIV program. And now we're talking about more complex care, and there is a tension here because we don't know how to do. And I take just my hat from the hospital. Also, this is my hat, I have to say. And I was just amazed last week because people ask me about whether we can treat cryptococcal meningitis in ambulatory care. I've treated many cryptococcal meningitis, but always in hospitals. So that was something new for me. There is no guidelines. I was looking before departing to everything I could about whether there were some models about how to lightly treat this cryptococcal meningitis with 30 to 50% mortality rate. How can we do? And frankly, there is nothing. So there will be something new. We will have, I mean, MSF will have to be very creative about testing these new models, but also not only saying about operational research, but getting the data of that, because it's one thing to treat lightly cryptococcal meningitis, but you have to be sure that you're not doing harm. So all of this makes me think that there is a tension about this message we had for the last 15 years about simplification and how we can now simplify more complex care. I'm sure it's possible, but the model needs to be invented.
We recognize that as an absolute priority. I think that certainly the ambulatory management of advanced, of course, if people can walk, is something that we're developing and working also with WHO on that. But I think it's a priority for us right now. But I would still maintain that those are the exceptions to the rule in terms of our knowledge of both the tools and the strategies to deliver care for advanced patients and stable patients. We are so far advanced compared to where we were before, and the problem is where we are not implementing what we already know. And certainly we do have experiences of ambulatory crypto management in some of our programs, so we can discuss it more.
Thank you. I think we have time for some more input from the audience, and then we will try to wrap up. Yes, so there's there, Abi, I think, yeah.
Thank you. My name is Abi. I've been with MSF for several years, and then I left, and then I came back. My question is more of a comment. First of all, I really appreciate what has been discussed by all the panelists. From the points that have been made, my question is, it looks like we are winning the battle, but are we winning the war? We are developing several tools. We are implementing HIV programs, integrated, non-integrated, in several missions. We have tried always to simplify, to task shift. All these have been, I think, something that we have capitalized over the years to a point where we feel comfortable treating HIV patients anywhere in the world. In fact, our experience has been transmitted to others, but my question is, what does it mean in terms of MSF going to the next step of addressing the issue of controlling HIV and other chronic diseases? in that regard, I think we have not really worked so much, in my view. We still consider ourselves as implementers and not enablers. We have seen how the other systems around us are really poor in quality, where there is a lot of corruption, even on HIV testing tools and so on and so forth. So MSF, how are we using our knowledge, our understanding, and our ability to influence others in addressing these issues? If the panel is thinking that this would be part and parcel of the next reflection of the strategic frame, I think that would be the right direction. If not, the discussion of whether we should be in high prevalence or low prevalence countries is almost secondary, because sooner or later, the rat tail effect of any kind of outbreak will put us in a position where we are less and less in control of the various variables, and we rely on others for implementation. And even if we work in countries where there is high prevalence, we will be depending on other actors, other stakeholders for success of our missions. So unless MSF take one step and view strategically how we want to address the current situation of HIV and other chronic diseases, then we may lose the war, even if we are gaining the battle.
Thank you.
Charles Sonko, HIV advisor from OCA. Thank you very much, the panelists. But I just wanted to go back to the low coverage settings. I think we are overgeneralizing these settings by calling them the West Central low coverage countries. But I think we need to reconsider the fact that in these countries, there are also conflict settings where I think where there are conflicts and where there are no conflicts, the packages of care to deliver there are quite going to be different. I think with the experience we've got from conflict countries, we actually coming with very specific models where you don't need even to be on the ground to continue treatment for patients, because from time to time, you're going to be packing your bags and leaving these projects. But the patients are going to remain and they will need treatment to continue. So I think this context, we need to really design packages, as Cecilia already mentioned, that are really specific to the context where we are. The other thing I wanted to comment is, even though they are low coverage countries, but there are also settings within those low coverage countries that are actually very high coverage. Which are very high incidence and very high prevalence settings. For example, for instance, Zemio has a prevalence of, an incidence of about 12%, which is quite very high. You had Christian mentioning the numbers we are already treating there, over 1,500. So these are quite very high, comparable to even settings in Southern Africa.
Christel?
Yeah, it's questions from OCA in Zimbabwe, and they are a little bit in line with those two, so that's why I'm going to take them now. The first one, high prevalence versus low prevalence, which has more risk for future epidemics, especially considering that in low prevalence countries, public awareness about HIV is extremely low and stigma is very high. That was the first one. And the second one may be more in line with the second question. There is an understanding from the mission for when it comes to the broad spectrum approach, but is it necessary to proceed with HIV activities as a blanket, or should we be more selective, focusing more on gaps and specific groups, like teenagers, prisoners, or treatment failures?
There is a question from Mitt. Also, should we take that? And then I think I'll leave the space to everyone in the panel to react to the question, but also make whatever you want to make as a last statement in this debate. Yeah, but Mitt, please go ahead.
Yes, I wanted to come back also to this issue about what priority is given to these patients and the 10% and 10. But I think it's interesting to go back also to the beginning when MSF started in HIV. People always get very excited that MSF shows it's feasible, how to do it, and so on. But in fact, by getting it done, doing it, we also established a position saying it has to be done. It is a right for those people to get an extra lease of life and to have treatment. And so, and where I'm very worried also is now that in the changes in the environment, this right is being eroded. And for some people, like in the low coverage countries, it will be very difficult still to make that right work. And so I think it's important for MSF also to position itself in that discussion and not to withdraw in only the technical side of things. So I'm really sometimes upset also by, you know, the frustration. The only frustration of MSF seems to be, why are these ministers of health not taking over from us? We started this, now they have to do it. The environment is not so positive anymore. And I think where we have not discussed today, it's also the collaboration with civil society, patient associations, because they will be able also to reinforce that call for their rights also. So I think we need not only to embrace the technical improvement, but also more the civil society and the positioning, really. And it didn't come up in the discussions yet, but I think we have plenty of experiences and opportunities to do that.
And it is clearly part of the lessons learned, I think, from the earlier days, where that was a key component that needs to be continued thought of. Christian.
Yeah. So maybe to pick up there, Meet, on that one, because I think you are completely right, and I would agree there that I think, you know, and excuse my simple words, again, being non-medic, but I think we should rather go towards, you know, an advanced drug distribution programs. That should be our aims in terms of first line and second line after diagnostics, rather than having a medical program around that, because we have to circumvent the health system, which is not there. Yeah. So, and I completely think that this is, you know, you should then, you know, enable and encourage the patients themselves actually to take that into their hand. Because what we see, for instance, in Central African Republic, that the drugs are there, they're sitting in Bangui. And then if you, in a way, enable a group of patients to get access to those drugs through whatever means, that's then the potential way forward. And potentially you have to take out the whole Ministry of Health along the line in order to enable the patient to get there. And I think that also answers some of the questions coming out of Zimbabwe for me, where you have this free care versus cost recovery or whatever, but in the end there's costs involved. And then as an organization, we can always make the choice to cover some of those costs in order to enable and show people how it works, but also we can, from the beginning, just accept the fact, as we do in handing over programs, that there is cost associated to accessing drugs if they're available in country, and discuss rather with the patients what is the smallest amount they can actually afford in order to get to those drugs. And then, you know, some of the experiences we had in Southern Africa around community treatment groups, etc., that's definitely a model we see we can have working also in you know, in these more conflict-related, low-prevalence countries, and discussing with the patients how they get to the drugs, rather than making sure that the drugs getting to them. I think that's really what I think we have to work hard on from an operational side to make that happening. I completely agree there with you.
Thank you, Christian. David, are you there? Would you like to comment and give some concluding words from your side? We only have the photo, which is nice, but
it's enough.
Yeah. It's nice.
Ask the question, so if you're not there, and we'll see.
Is he online streaming? Yes. No. Okay. But why don't we'll see if we can come in at the next, and then perhaps Pierre, if you want to give some input.
Yeah, to react on the comments that was done about winning the war against HIV and not only battles. So if winning the war means seeing the end of HIV, I don't think that we should pursue this objective. I don't think it's realistic. I suppose that given the technology available, it's not possible, and the only thing that would make it possible would be to have a vaccine. So if we want to win the war against HIV in general, let's put all our money in vaccine. But it's not so much what actually, I mean, our experience and what we try to do leads us to, and we can as well focusing in winning small battles. It's cool.
Thank you. Tom?
I mean, so I'll pick up a bit and finish on. Yeah, the title of this was The End of an Era, so it does ask us to reflect what era is ending. And I think far from talking about winning a war, we're actually looking about progressively rolling back the successes of the years at the moment. We've moved from an era of urgency and of community engagement and activism to an era of complacency. We've moved from an era where there was increasing funding to last year, for the first year, massive drop in global funding for HIV. We have all of these tools that we know how to use, all of these experiences, and yet we are still seeing the same problems. Even in Kailicha, one of the oldest programs, the numbers of people presenting with a CD4 below 100 has flatlined for years. The difference is that many of those people have now dropped out of treatment. Same in Kinshasa in our program, 70% or more of the people dying in the hospital were on treatment in the past. And yet there is a sense that something has been achieved. So for me, that point that Mitt made about what is going to maintain the engagement of HIV relies on our engagement with civil society. And I don't think that we have put in the investment we needed to understand why communities and civil society in general, but communities at our project level, are so disengaged from the coming failure of governments to respond and to provide care. So for me, HIV was always a driver within MSF. In the past, there has been a problem of battles between HIV exceptionalism versus all of the other needs. In the global environment at the moment, that's only going to get worse, with the fall in funding, not just for HIV, but globally for healthcare, and interest in things outside America and Europe generally. So the challenge for me is, how do we ensure that HIV maintains not an exceptional place, but funding sufficient to respond to its needs, and to ensure that that experience of HIV is leveraged across healthcare in general. And I think that that is the era we're coming to now. I think that we're in a really, really dangerous phase, both internally in MSF, in humanitarianism in general, and globally, around a response to HIV that we fail to recognize at the moment what risk it is in and what damage a failure there will do to a more global response to health needs in developing countries, in conflict areas, low coverage, high coverage, whatever it is. So I argue for the centrality of HIV still to MSF's learning, MSF's responsibility, and the global response for health.
Thank you, Tom. I think you wrapped up very nicely. But I would still like to give some space to Cecilia and Alexandra and David to say some final words here. I'm sorry, because there's no more space also to take questions from the people streaming in, because we do need to finish the discussion very soon. David, are you there now? Yes. Hi, David. We hung up, maybe. I don't know. Okay, then Alexandra, would you like to give some more comments before we...
Maybe one or two sentences, because Tom, you really expressed very well our concern, and that's not only a humanitarian-based concern, it's everywhere. I think there are many gaps. We have pointed out many of these gaps, the second cascade, the 10-10-10, etc. And MSF cannot fail addressing this gap. So this may be the new era. Even so, I do agree that we cannot leave out everything that we have learned before, which is very important. There is a sense of HIV fatigue everywhere. And this HIV fatigue may translate into decrease of funding, but also less new people interested with HIV. It's very difficult to recruit young doctors interested to HIV, just to give an example. So, and we are not very young here. We were. Anyway, so I mean, there is this sense of HIV fatigue, and if MSF can do something to keep on HIV on the top of the agenda, because it kills many people, at least in the high prevalence country, it's a deadly disease. We have the tools, we know how to address that gaps, and I think that should be a duty for MSF, because it's a right for the patient, and you mentioned that, and I think that was very right. We haven't kept this point very high. So I think we should fight against the HIV fatigue and keep HIV on the top of the agenda, having new objectives, more sexy, as you mentioned, Cecilia, before, because there are many, many things that needs to be done to address and to fill the gaps in HIV.
David? David, you're there now, I understand, so...
Yeah, I'm back. I'm sorry, I got cut off. No, I do think as a conclusion that we sometimes forget the knowledge and the techniques of what we've learned throughout the year. Something that Pierre did not really mention in the evaluation was that NDIWA actually used all the experiences in decentralization, task shifting, supporting, and that was learned in the past year in order to implement that very, very fast in a new setting, actually. And I do think what could be done in other countries is all this approach toward the simplification of care, task shifting, decentralization, simplified access. And I do think that we have a huge experience today to share. And same for advanced patients. There is not so many medical organizations who have, with the capacity we have in order to scale up advanced HIV care. So I do think we should really use and keep on using our experience in the coming years in new settings, maybe. Well, thank you.
Thank you, David.
Thank you.
Yeah. And Cecilia, as the leader of the working group, then, what do you take with you from this discussion?
I think that, as usual, Tom has been very assertive on the wrap-up. I think that we have a lot of things to work right now for the following 4 years, but I see mostly, I mean, we have already recognized the gaps. I fully agree with Meet and with Alex about the fatigue. I think this fatigue is not externally only, it's not only Global Fund who is fatigued of HIV, but I think that there is an internal fatigue that we need somehow to overcome. We need to be, and this has to be discussed between the AIDS working group, between the medical departments, how to re-engage operations on this job. I don't think it's the end of an era, because that era will not end. We don't want to close those projects that are still building evidence. I think this is a phase of consolidation of that 20 years of experience and the beginning of a new one in those settings where we are still struggling to implement basic activities that we know how to do it, but somehow, and there is no answer to that, we don't know why we cannot extrapolate there. And the last thing is going to be related to the 1990s. I think that we are putting a lot of pressures on ourselves with this 1990, while the ones who said this 1990 are not that stressed, which is UNAIDS. So I think that although we need to keep fighting for those 1990, we need to accept that in some settings, this 1990 will not be that much, will be a 50-50-50, and at least for some operational centers, this will be acceptable. So, and we will have to learn to live with that, because perhaps this is the maximum that we could do for that. And that's all from this side.
But maybe the question then from an operational side is, why do we accept others to tell us what needs to be done. So that's my challenge back. So why do you accept 90-90-90? And
Because
that's
we
your
believe,
big...
we engage. It was a supportive, I think we all agree that this 90-90-90 needs to happen, but it's not MSF necessarily who has to do it. So this is why we, as Mead mentioned, we need to be now more clever on calling other implementers. I think the approach for the Western and Central African countries is going to be this one now. Rather than becoming implementers, we want to call others to get in, and we can show you what has been our experience in other settings for the last 20 years. Let's see if it works. But I mean, we do engage on the 1990s because we believe that it's going to be the only way to tackle this epidemic. But we need to be flexible enough within our operations to know that in some settings, this is not going to be feasible.
I think we have to take that as the final remarks on the discussion. So it is, in a way, not the end of an era, because we are still struggling with a lot of the same questions, but we're also facing new ones, and so we're moving into a new era with the baggage with us. Thank you for being so patient. Thank you for staying over. Now it's time for lunch, and we shall try to convene here again at 1 o'clock-ish, or 1 o'clock, yeah. Thanks so much.
I mean, we won't, but if you say 1:15, then
Yeah, no, that's
become 1:30.
Yeah.
Who is it? Juan. Well done.
Okay. Everyone looks